Okay, thank you so much for joining me. It's great to have you here. I'm just going to give a little note on language at the top. We're going to be using the term women and female today, but really we're referring to anybody who has ovaries, which includes trans and non-binary people. So to kick off, and we're going to keep this brief because it's kind of a sad answer, I'm going to imagine, but can I get a sense from all of you where we are with regards to female healthcare today? Do you want to kick us off, Jennifer?
Sure. I think we're in a space with women's healthcare where physicians aren't properly trained, women don't get the care they need, and I think a lot of women don't actually understand fundamental things about their own bodies. So yeah, we'll get to the good stuff later, but that's sort of where we're at right now.
Yeah. Keisha, how about you?
We're not in a great place at all, actually. In the UK, we have the widest gender health gap in G20. 12th largest globally. The data are quite bad. Less than 2.5% of publicly funded research goes towards reproductive health, when 1 in 3 women suffer from reproductive health problems sometime in their lifetime. It just really isn't good. So we need to address this urgently. We're talking about 51% of the population, and we hear all the time about how, the last year when the government did a women's health consultation, more than 80% of women said they didn't feel comfortable talking to their healthcare professional about their menstrual problems. We have nearly 1 million women who have left jobs because of menopausal problems and the employers not supporting. I can go on, but we are not in a good place as a nation, and we need to urgently address that.
Kate, how about you?
I'll maybe take it in a little bit more of a positive direction. I think, for all the reasons that you just spoke about, there's an urgent conversation to be had. But certainly when I started Maven 9 years ago, the conversation wasn't being had at all. And so I think the fact that we're on this stage talking about it, a global dialogue is being had at the top of large institutions, large employers, that finally change is happening. And it's not without its challenges. You mentioned Roe v. Wade, of course, which is a major step back for in the US for healthcare for women. But I hope that I have a daughter, and I hope that by the time, she's only 5, but by the time she really thinks about and starts to receive, core women's healthcare, that we will have definitely made progress.
Mm-hmm. Yeah, Jennifer, I know last time we spoke, you kind of chafe against all the pessimistic statistics. And you choose to be a little bit more optimistic because you think, we're kind of at the beginning of this kind of meteoric change when it comes to women's healthcare. Can you talk a little bit more about why you're maybe cautiously optimistic?
Like Kate just said, I think, there's a sea change right now that's happening. There's a moment that's happening right now where I think we've definitely started to shift the societal viewpoint. There are taboos that are being shattered. I think, 10 years ago, we didn't talk about menopause publicly. We didn't talk about women's bodies, menstruation, things like that. And suddenly the public dialogue is there. I do think, though, that there is still that people tend to think about women's health as like a niche subcategory of medicine. And so what needs to happen now is that we need to start thinking about women's bodies as a whole instead of, treating one organ system at a time. But right now, I think that there is a huge amount of interest from investors in this space. There's a huge amount of interest from us on the research side in terms of just bringing women's health and the data around women's bodies up to the same level at which we understand male bodies. And so I think there's a lot of really exciting things happening.
Mm-hmm. Something that, all your work kind of has in common is that it's kind of giving women the opportunity to take control of their own fertility. So, for as long as it has taken, it's just always been a given that, women have to abide by nature. And when that window closes, it's slammed shut and that was it. But that kind of feels like it's changing very rapidly, with advances in science and medicine are kind of giving that women the autonomy back. So I guess kind of fertility, as we know, it is kind of changing dramatically. Obviously all of your work kind of involves this. So maybe Geeta, can you talk a little bit about your work in this area when it comes to giving women control back of their own fertility?
Yeah, as regards to fertility, once again, in the UK, we have 1 in 7 couples having fertility problems and looking towards IVF. And fertility treatment is an essential medical treatment. World Health Organization, long time ago, and I was part of that group where we actually worked towards getting the WHO recognizing fertility as a disease. And also, apart from helping people create families through treatment, it also gives us a great opportunity to create a diverse society. We can help single women, same-sex couples. I mean, what better opportunity to create a diverse, progressive society, as well as creating families, very much needed. So when it comes to helping women take control of their fertility, there are a number of things we need to do. The first thing I think is we need to move the conversations from clinic rooms to classrooms, committee rooms and conference rooms. So the education is absolutely fundamental, and we introduced fertility education in some London schools in 2017 after looking at the core modules and the curricula, where there were lots and lots of gaps. So we need to introduce fertility education in schools for boys and girls so that we can empower them with the knowledge to decide about their future. We also need to help with this education in the NHS. I know I work in a different system, but clearly we have to be able to help people with fertility problems on the National Health Service. Right now, unless you're trying, you can't go and get your fertility tested. So we need to move towards screening for fertility. If people would like to get their fertility checked, we need to end this terrible postcode lottery that we have got in the UK. And it goes totally against the founding principles of our National Health Service, which is access to equal and fair care, regardless of where you live and your background, your sexual orientation, and that's not happening. So education, one thing, access to care, quick diagnosis, equal and fair access to treatment, all of these will help. But certainly right now, as much as I love we are talking about it, we need to move from talking to action to actually deliver this from our government, which right now published a women's health strategy, but there's not much happening, so we need to get that into action. We need to get all sectors together, public, private, voluntary, community, everybody together into this so that we educate women and men and everybody who is wanting to create families can change their lifestyle, can make themselves more fertile where it is possible and get access to care and improve outcomes.
Kate, I know obviously your Maven clinic is kind of operating firstly within the US healthcare system, which has its problems. So you could argue that your company is kind of doing just that, giving women the opportunity to control, a variety of things to do with their health by themselves through your clinic. Can you talk about that a little bit more?
Sure. So we're actually global. We started here in London, moved to the US, and really excited to be back. We have about 70 clients here. And one of the big things that we really pay attention to is how to bring continuity of care through the whole lifespan of reproductive health and family care. I think that is empowering in and of itself. We see some of the biggest areas, fertility is one of the biggest areas, I think, that has experienced the most change over the last few years. And we see, particularly here in the UK, that being one of our biggest growth areas, along with menopause. I think the way that we look at all of these, parts of and phases of life that women and families go through is we really look at across three areas: financial, clinical, and emotional. On the fertility side, I think we are finally at a point where fertility benefits and covering it, which has been one of the biggest barriers to getting care. And it's a huge health equity issue, as you were talking about. I couldn't agree more. Health equity and needing to improve it, particularly through the fertility journeys, is hugely critical. And so, there's more financial support coming online. A lot, we power that for a lot of companies, but governments, health plans, health systems, there's major steps forward. I think on the clinical side, making sure that women have the right information to make the right choices about their health. So that's really important. And then on the emotional side, I think mental health has been completely underserved and overlooked. When people ask me sometimes, what is women's health? It's like, how do you not know that sometimes? But I do look at it as kind of the intersection of reproductive health and mental health. And so whether it's, the stress and anxiety that one has in their fertility journey, just being an underserved patient in the system, whether it's, needing support around loss, miscarriage support, postpartum depression. There's a lot of hormones in women's bodies that, have to occur to have babies and bring babies into the world. And then what does that do to your mental health? And, how do you interact with society? So I think that's the other big area that we really focus on in terms of kind of bringing a more holistic model.
Mm-hmm. And then Jennifer, I know you're giving us a talk later where we get to hear a little bit more about your research. So I wonder if you could give us kind of a snapshot really quickly of your work, because obviously, we could talk about giving women the opportunities to, go for IVF and stuff like that. But your work is really kind of turning everything up on its head. Could you talk about that a little bit more?
Yeah, sure. And then not to diminish the fertility side of things, I think that obviously a woman's ability to carry a child is very important, and particularly around mental health and things like that. But we're thinking more about women's bodies and their reproductive organs from the perspective of general health, right? So separating women from mothers or being incubators. Fertility and overall health are completely intertwined, and ovaries are making a whole cocktail of hormones that are really important for general health that have nothing to do with reproduction, with actually, fertility. And so what we're trying to think about is understanding how and why ovaries age prematurely. So, and what that impact is on a woman's overall health. Going through menopause is one of the most dramatic things that can happen to a healthy woman's body. It really does speed up aging. And so separate from, fertility and a woman's ability to reproduce, this reproductive decline that happens really does impact every aspect of a woman's life and well-being. And so thinking about understanding how and why ovaries age prematurely, this is what we're really trying to focus on. So in my own research, this is what we work on. I'm a neuroscientist, so I'm really, really fascinated by the connection between the brain and the rest of the body and how the brain controls things like systemic aging. But more than that, what we're trying to do is to stimulate research in this space. So this is an area, women's health in general is just underfunded, understudied, and underserved. But from the perspective of ovarian aging, thinking about reproductive aging from the perspective of health, this is something where there has been very little work done. And so there's a huge opportunity to really stimulate innovation in this space. So we have a nonprofit which essentially is funding research and also trying to build the network, essentially to build this ecosystem around bringing things from the lab and the discoveries that we make at the bench into women's hands faster.
Something that I want to devote a little bit of time to, because you've all alluded to, menopause is something that we just never really talk about. Even though half the population experience it, it has massive health consequences. And number one, we never talk about it, and probably because of that, we know so little about it. There's just so little research about it. Jennifer, I know you even kind of don't really love the term menopause, and I want to hear about that in a second. But yeah, I'm interested in hearing from all of you why it's so important that we start talking about menopause more and devoting more research to it. Jennifer, can you tell me why you hate that word?
Well, menopause, it's femtech that I hate.
Yeah, I know you all hate that term as well.
Yeah, I agree.
We don't talk about dude tech, do we? So why would we talk about femtech? It's health tech. Menopause to me, menopause is defined as a single day in a woman's life, right? So it is the day on which a woman has not had a period for 12 months. So that's fine. But what we're really talking about is this transition from having, all of these beneficial hormones that are supporting bone health and brain health and muscle health and all sorts of things, to basically a state where a woman is at higher risk for a whole host of diseases. And so menopause makes it sound like it's some sort of, just something that happens to you while you're, having a nap. So it doesn't really capture what's happening. And I think that we could really change the dialogue, change the language around all of reproductive health, so that we're not just talking about, even just using the word reproduction really diminishes what we're talking about. And separating fertility and childbearing from the overall health impacts. This is, why I would love to change the language. Anyone who has any bright, inspired ideas, please.
Yeah, you can put that on the slide. Geeta, does that shine for you?
Yeah, well, look, I mean, when we're talking about health, we're talking about what percentage of people does that particular condition affect? Is it 25%, 50%, 10%, 5%? But there is one condition that affects 100% of women, that's menopause. Everybody goes through menopause. So it is an extremely important condition in a woman's life course. And it's not, while by definition it's just one particular moment when the period stops, but it is not just one moment. It stretches over a few years, and the symptoms can affect the quality of life. It can affect a number of our organs, brain, bones, heart, a number of organs, and they lead to, I mean, women, although live longer, the quality of life is, they suffer from chronic illnesses. Menopause is one of the main reasons because of chronic illnesses, and that affects their quality of life. And we know now from the work that is going on that we have had nearly 1 million women who have left jobs because there's no support at work. And we know a huge proportion of our workforce is women in their 40s and 50s. So it affects all women in the first place. And secondly, there's premature menopause, early menopause affecting younger women, and treatments affecting women's hormones and menopause. So if we address menopause in the workplace, so we need proper policies, we need support, and we also improve care, because there is a lot of stigma associated with it. Women are not getting the care they need. Then I think we improve women's health. So menopause affects every woman, and it's very important we improve care and conditions for women and policies in the workplace.
Yeah, that kind of relationship between women's health issues and the workplace, I think, is a really interesting one. There's so many things that we're expected to do as women, go to work, while these issues are affecting us, periods, and also menopause as well. And it's something that we're just not supposed to really talk about. And I know, Kate, a big part of Maven Clinic's kind of ethos is kind of changing that relationship between motherhood and reproductive health, et cetera, and the workplace. Can you talk about that a little bit more?
Sure. And actually, menopause is one of our fastest growing products in the workplace. So, and that was originated here in the UK in 2021 and has since, I've never seen a product sell faster than our menopause product in the last 4 months. But I think, one of the big things that global employers are really looking to do is, build a more equitable workforce. And when women's health is so underserved in the global health systems that we live in, that ultimately does create gender imbalances at the top of corporations. And so and the governments, let's be honest, are behind. And so what that means is a lot of companies are left to actually try to figure out how to do something about it, which is where Maven fits in, is we help companies and health plans back in the US and, ultimately, health plans, we're starting to have conversations here, is how to design the best benefit that brings not just better women's health products and support systems into the workplace, but really family health too, and bring more equitable pathways to parenthood via surrogacy and adoption products, and then really drive better outcomes. Because when you have complications across any of these areas, then you're missing work, which is there's not just clinical outcomes, but there's business outcomes as well. And so it's been wonderful to really be able to see this pathway accelerate, and that also puts pressure on governments, policymakers, to change the dialogue when you have big business leaders saying, hey, why is the C-section rate so high? Why, are so many of our, the LGBTQ community, not have equitable benefits? And so, and then these conversations are being had at a policy level, which is great.
Yeah. And then I think the question around, making change in women's healthcare, sometimes I think it's easy to get pessimistic because so many of the barriers are so deeply ingrained in society, taboos, sexism, misogyny. But, I'm really interested in hearing from you guys, apart from, undoing misogyny, an easy task. Can you talk about maybe some of the low-hanging fruit that we can tackle today. And I know, Jennifer, part of your work is funding, which is obviously super important. And as we've alluded to, funding for women's healthcare is just like at the bottom. So can you talk about that a little bit more, why it's so important that we actually get some money into this research space?
I mean, sure, there's just a total lack of data. So we don't understand the most fundamental things about what's happening with women's health. We don't understand, what the causal drivers are that are essentially pushing ovaries to age faster. We don't understand things like what's the relationship between long-term hormonal birth control use and overall health. We haven't done those studies. There's a huge opportunity right now, and I think that women are hungry to participate in studies, which is amazing. I think that right now we're just kind of at the precipice of gathering all this data. We have all this, incredible opportunity with respect to low-hanging fruit, like finding new diagnostics and biomarkers, coming up with better ways to measure where a woman is in her reproductive health span trajectory, right? Like I should be able to go to the doctor every year and get some sort of a comprehensive test that's going to tell me where I am in my relative journey, towards infertility and menopause. Right now, that doesn't exist, and I think that there are a lot of really easy, simple things we can do that will make a huge, huge difference in every woman's life.
Do you think it'll happen?
Oh, it's happening right now.
Okay, good.
Yeah, for sure. I mean, there's a lot of, I would say, more complex questions that are going to require a lot more time and research. But in terms of biomarkers and diagnostics, I think that we're right there.
Mm-hmm. Geeta, for you, what do you think are some of the low-hanging fruit that we can tackle?
And there are lots of them, actually. Yeah. I mean, there are lots that could be achieved within the existing budget. In other words, we are not even looking for extra funding. And what we need, to me, is a collaborative action, intergovernmental action. At the moment, when we talk about health, in the National Health Service, it just lies at the door of the Department of Health and Social Care. But women's health is beyond just the remit of Department of Health and Social Care. We need Women and Equality, Department of Health and Social Care, Work and Pensions, Treasury directly. They all need to come together and put a pot of money towards women's health, because businesses get affected. If we don't create families, who is going to pay for pensions and equalities? And we haven't addressed that. In fact, the outcomes are quite bad, particularly maternal mortality rates. If you're a Black woman, you're more than 3 times likely to die in pregnancy and after childbirth. And if you're an Asian woman, you're more than twice likely to die after childbirth or during pregnancy compared to white women. So there are a lot of serious issues to do with equality in care and access and digital exclusion. So one-stop clinics is something we can establish to improve access to care, diagnosis, which is so much needed to improve outcomes within the existing budget, and education. I have to say, education is something that we can deliver and we should deliver without any delay.
Yeah. Kate, how about you?
Sure. I think, some of what Jennifer has been talking about is data. And I think as long as we can continue to fund more research, more companies that have a lot of data to really define the problems, that can really move things forward. Because, when you have actionable data to define a problem, then you can get more funding and you can do something about it. I was in Minneapolis a few weeks ago with one of the big national health plans in the US, and they had actually just put together a big presentation on all of the claims for women's health issues. And one of the things they said is, oh my gosh, thyroid disease disproportionately affects women. 80% of the claims for thyroid disease are female. And so all of a sudden, with an insight like that, then that fuels research, then that fuels action. And I think we've just been living in this data desert for so long in women's health, and so this is another area where I'm hopefully optimistic that things are changing, because there's finally more data to drive the conversation forward.
Mm-hmm. Yeah. Okay, I'm gonna take some questions now. This question I think Jennifer will like. And I guess a lot of what we've been talking about today is with regards to both fertility and having children, etc. But we know a lot of women maybe don't want to have children. And so someone asked the question, is female health seen mostly through the prism of fertility? What do you think about that, Jennifer?
I mean, I think historically, yes, obviously. It's named, and the words we use are specifically about fertility. But yeah, we're trying to change that. That's the whole point of what we're doing.
Yeah.
Yeah.
To both of you who are involved on the fertility side, do you kind of acknowledge that kind of bias sometimes in the research?
I mean, that's what's getting all the funding right now. So,
yeah. Do you think that's a problem?
I think you have to start somewhere. I mean, well, you know, so I think, you know, a lot of funding in fertility and maternity leads to a broader conversation about women's health. I mean, menopause has been now a topic we're all talking about. I mean, I think you need to start somewhere. Of course, in an ideal world, it's all equitable, but we don't live in that world.
Yeah, I agree with that. And we really need to have more conversations about both female and male fertility, because nearly 50% of fertility problems could be male fertility related issues. So we need that conversation. We need funding. No two ways about that. I mean, because research at the moment in fertility is not funded hugely. It's not a priority. We need to move that conversation.